Techniques in ablation of atrial fibrillation. Now, there's lots of different ways that people can approach ablation of atrial fibrillation. And remember, we said that it's not really always that important how you do something. It's actually more important what you do. So the example for that would be there's different energy sources, and sometimes people will say, well, I had a cryoballoon ablation where they froze it. And then somebody else has the standard method, which is radiofrequency, which is cauterization or burning. And then there's newer methods, such as the pulse-filled ablation technology, which has come out, and that uses electrical pulses to destroy cells. And then you've got the surgical methods. You have the old cut and sew maze, which is called a Cox maze procedure. And that is the one where people open up your chest, crack open your chest, and actually do a very extensive ablation all over the 6 walls of your left atrium and your right atrium. And that has the highest success rates in terms of getting rid of atrial fibrillation or turning the clock back to an earlier stage of your atrial fibrillation. But that's an open heart surgery procedure and requires your heart to be actually still in a heart-lung bypass machine. So then there's other surgical methods that are less invasive than a full Cox maze procedure, such as the surgical hybrid procedure, and then of course the Wolf mini maze procedure. So I think it can get very confusing as to the different methods and what you can expect from the different methods. So let's clear this up a little bit. So as I said, the energy source isn't always as important as what you do. How you do it, in terms of how you destroy the cells, may be less important than what you actually do to destroy the cells. And remember, this is all based on staging of your atrial fibrillation. What stage of atrial fibrillation are you in? The more advanced a stage, meaning the more AFib cells you have spread through more walls of your heart, then to get you a good result or to significantly get rid of your atrial fibrillation, or most of it, or turn the clock all the way back to almost zero, you're going to need a much more advanced ablation technique. People are going to have to do more to get rid of it. The what you do, not so much how you do it. Now, if you're at an earlier stage, you may not need as much done to get you a good result. So this is number one in terms of effectively treating your atrial fibrillation. What stage of progression are you in? And then that will sort of determine what you're going to need, because the success rates will vary depending on what stage you're at, which correlates to how much AFib you have and how progressed your forest fire is, if you use the forest fire analogy. And then there is how you do it, the energy source. And there are certain pros and cons to different ways of doing it, but the optimal approach will take both of these into account. Now, before I had used the analogy of a forest fire, if you say that your atrial fibrillation is like a forest fire, where it's always growing and growing and growing and spreading from 1 wall to 2 walls to 3 walls, and eventually all 6 walls of your heart, there is a rough correlation between how many AFib sources, cells, triggers, whatever you want to call them, there are in how many walls, and how much time you're spending in AFib and how difficult it is to get rid of your atrial fibrillation or get rid of most of your atrial fibrillation. Like the forest fire analogy. In the early stages, when you have a small forest fire, when you only have AFib on 1 or 2 walls of the 6 walls in your left atrium, which is the left upper chamber of your heart where AFib cells form, then it may not matter what procedure you have done, whether it be ablation from the inside or surgical ablation, whether it's freezing or cauterization or using pulses of electricity. If you have an easy forest fire, easy is easy. And it's likely you're going to have a high success rate no matter who's doing it, no matter what modality they use. But if you have a more progressed forest fire, where you're in it a lot more, where you failed multiple drugs to try to keep it asleep, the so-called anti-arrhythmic medications, then doing a very simple approach isn't going to work. And the likelihood of success is going to drop significantly. So that's where you would need much more complex approaches to try to significantly get rid of your AFib or turn the clock back to an earlier stage on your forest fire and either make your forest fire a lot smaller where you're going into AFib a lot less, or hopefully all the way back down to zero. But remember, it is not an all or nothing phenomenon. When one does a catheter ablation, it's not like we go up, map these abnormal cells, and then wave a magic wand and have the cells just magically disappear, and either you got it all or you didn't. It's really not as simple as that. It really is more like putting out a forest fire. And with a more complex forest fire, that's a lot more spread, you need a much more comprehensive strategy where you're gonna go after a lot more areas of the forest. So keeping that in mind, let's run through the basic anatomy and then what the different approaches do and why there are pros and cons so that you can better understand why each approach may have more or less effectiveness based on the strategy they use, and then of course, to a certain extent, a little bit, what energy source they're using. So, basic anatomy about the atrial fibrillation. Well, we said that atrial fibrillation is abnormal sources of electricity that form in other walls of your heart that randomly wake up, take over control of your heart away from the normal source of electricity that powers your heart, which is in the roof of the right upper chamber of your heart, the right atrium, and then tells your heart to speed up. Well, the walls of the heart where atrial fibrillation are located is the left upper chamber of your heart, the left atrium. Now, using the simple analogy of a spreading forest fire, if you think of that chamber as having 6 walls, the back wall, which we call the posterior wall, the front wall, which is the anterior wall, the roof, the floor, and then 2 side walls. One side wall is called the lateral wall, and one side wall is called the septum. Now, if you think of this as a forest fire, and you think of the atrial fibrillation sources or cells starting in one wall and then slowly growing more and more and then spreading to all the walls, then that would be what we discussed in terms of the more walls you have AFib cells on, the more AFib cells you have total, and the more it tends to wake up. And that's where you would be at a more advanced stage. Now, we also realize that there are stages of atrial fibrillation. These are the early, mid, late, permanent stages. So paroxysmal atrial fibrillation, which is atrial fibrillation episodes that last for less than 7 days at a time, that would be the earliest stage or correlate to the smallest forest fire. Usually that correlates to AFib sources or cells on really just that first wall, the posterior wall. But then as you spread to 2 or 3 walls, then that's where your AFib starts to wake up more and more and starts to become there for longer periods of time. That's when you progress into the next stage, which is called persistent atrial fibrillation. And that's defined as atrial fibrillation episodes lasting longer than 7 days at a time. And then when your AFib keeps spreading to usually 3, 4, or 5 walls out of the 6, where there's so many cells that it's waking up most of the time, then that's where you progress into the stage we call longstanding persistent atrial fibrillation. And that's defined as you're having episodes lasting longer than 7 days, which puts you into the category of persistent atrial fibrillation. And you've been like that for at least a year. So these people are mostly in atrial fibrillation. And remember, we said that when your atrial fibrillation gets to all 6 walls, that's when you have enough AFib cells that it's 100% awake. We cannot get you out of it. No ablation, no matter what the strategy, no matter what the energy source, no antiarrhythmic medication that can keep these cells asleep will work to keep you in normal rhythm at that point. That's when we say that your atrial fibrillation is permanent. And that's when we can't get you out of it, and we just slow it down with rate controlling medications and say, as long as you don't have a clot and a stroke from it, that's fine. We're just treating symptoms, but we can no longer get you back to normal rhythm. Now, getting back to the anatomy. So when we say that AFib spreads from wall to wall to wall, well, we know that atrial fibrillation always starts in that back wall, the posterior wall. In fact, specifically, it starts in the corners of that back wall. So in the corners of your posterior wall of your left atrium, that's where AFib starts. And actually there's some veins that drain blood from your lungs back into that chamber. They are called pulmonary veins. So as those veins insert into the four corners of that back posterior wall, that's actually where AFib always starts. Now, when you're only having AFib sources or cells in the corners of that back posterior wall, usually that's when you're at an early stage. That's when your atrial fibrillation is only awake some small amount of time, 5, 10, 15, 20% of the time, and you're mostly not in normal rhythm. Now, that doesn't mean you won't have symptoms just because you're not in it a lot. Remember, the symptoms of AFib have more to do with how fast your heart is going at when you're in AFib, not always how much time you're spending in AFib. But that is what we call paroxysmal atrial fibrillation. And that's where the basic strategy of ablation is to do what we call pulmonary vein isolation, PVI for short, pulmonary vein isolation. So most of the ablation strategies are aimed towards getting rid of those AFib cells on the four corners of that back wall. And that's because that's where AFib always starts. But whether you use cauterization, the radiofrequency ablation catheter, or whether you freeze it using a cryoballoon, or whether you use the new pulse field ablation energy source, which is pulsed electrical impulses to destroy the cells, it's still just isolating or getting rid of the AFib cells in those four corners. And that still correlates to a fairly small forest fire. And that's why easy is easy and hard is hard. If you're at an early stage, it doesn't really matter what energy source you use. If you're competent at any given energy source, you can get rid of those AFib cells in those four corners, and it doesn't really matter whether you use freezing balloon because it saves you a little bit of time, or the pulsed electrical activity or pulse field ablation because it saves you more time. Yes, there are some minor differences in terms of the fact that freezing is safer in general than cauterizing, and the pulse field ablation is safer because it causes less complications than even freezing. But the point I'm trying to make is, if you have an early stage where that's all you need done, you can have a good success rate irregardless of what energy source you use, as long as you go to somebody competent. But if you have a more progressed stage of atrial fibrillation, such as persistent or long-standing persistent atrial fibrillation, where you have more walls covered with AFib cells, then getting rid of just those four corners is not going to be enough most of the time. That's why when you look at these success rates, even when somebody's competent at their energy source, whether they're using cauterization catheter or freezing or doing the pulse field ablation technique with the newer energy source, the success rate for early stage atrial fibrillation, the paroxysmal atrial fibrillation, is high, 80 to 90%, assuming you're doing a good job and actually getting the result, not somebody who's not doing a very good job and doing it 3 times to get that result, and they're charging you for 3 procedures to make money. No, as long as you're doing a good job, the success rate is somewhere in the 80, 90% range. But when you progress to a later stage where you have a lot more walls than just that, then the success rate is going to drop significantly. When you go to persistent atrial fibrillation stage, that's when your success rates are 40 to 50% range. And then of course, if it goes to long-standing persistent, especially as it gets closer and closer to being permanent on all 6 walls of that left atrial chamber, that's when your success rates will drop just by doing pulmonary vein isolation alone to 10, 20, 30%. It's very low. So in these situations, what you do is more important than how you do it. Yes, there are some pros and cons and some advantages to certain energy sources, but for many cases, they're just not doing enough. Also realize that when we make these classifications, they're just arbitrary demarcations. We're just arbitrarily saying, okay, people with AFib episodes lasting 7 days or less, we're going to call that paroxysmal atrial fibrillation or early stage. People who have more than 7 days, we're going to call that persistent or mid stage. People who are lasting longer than 7 days and have been that way for more than a year or two, we're going to call that late stage, and then of course permanent. But it's really a continuum of disease. It's not like the cells go, oh, I'm going to be at 1 wall or 2 walls, and then instantly I'm going to go to 4 walls or 5 walls. It's gradual, year by year. As you get older, these abnormal AFib cells are forming, and so you're going to progress. But that's what I see as one of the biggest limitations in how everybody does it, is because it's so much more difficult to do a more complex ablation, the vast majority of electrophysiologists or electrical cardiologists don't do a whole lot more than that, the corners of the first wall, the pulmonary veins, or isolation of the pulmonary veins. And therefore, it's just a matter of, well, if you're an early stage atrial fibrillation, what we call paroxysmal, you're gonna have a higher 80-90% success rate with them doing your procedure. But if you're at a later stage, your success rates drop precipitously to 40 to 50, 40 to 60% range if you're persistent, or 20 to 40% range if you're long-standing persistent. So for those of us who do much more complex ablations, it's always a question of, well, how do we get a better result? If it's not so much the energy source as important as, if you're competent, that is, if you can get the result regardless of the energy source, it's kind of what you do. Well, then we realize that there are a lot more walls that you may need to do for certain people if you want to get them a better result. If you didn't want to just keep, if you have a forest fire that's say 70% and somebody just does that first wall or the corners of the first wall and they're getting rid of say 15 or 20%, well, that's still leaving you with 50% of AFib cells or sources on other walls. And so of course they're not really getting you the result. And especially if they do that over and over again, it's kind of an effort and futility, in my opinion. So if you're saying, well, what more can be done? If you realize that AFib spreads to these other walls and you need to target them if you want a better result in these more advanced cases, then it becomes, how can you do more? How can you do more advanced ablations? Now, there are certain modalities and certain strategies that are doing a little bit more advanced ablations. So some people, some electrophysiologists have advanced their skill set so that they can do more. Now, some people are doing things like the entire posterior wall, because after the AFib cells or sources form in those corners, which we call the pulmonary veins, the veins inserting into the corners, it kind of spreads to the whole posterior wall itself. And so some people are getting rid of the cells on the posterior wall. They call that posterior wall isolation. They're talking about electrically isolating the posterior wall to get rid of any of those abnormal AFib cells. And then of course it spreads then to the roof. So some people are doing the posterior wall and the roof, and that's not bad. That is definitely a more advanced ablation and will get you more results with a more advanced case. But also realize that even though we put these arbitrary boundaries of the different classifications and say, hey, early is up to 7 days worth of symptoms, and then more than 7 days is persistent, and then long-standing persistent. Remember, it is more of a continuum. And lots of times I go in there and somebody fits the criteria of paroxysmal atrial fibrillation, where they're having episodes less than 7 days at a time. But then when I go in there, I'm able to see or wake up more AFib after getting rid of the AFib sources in those four corners or the pulmonary veins. And clearly they need more. Sometimes they have it on the roof and the posterior wall. And for whatever reason, even though they have more AFib sources or cells on more walls, it's just waking up less. So it's not an exact correlation. So just blindly going in and saying, I'm just going to do those four corners because it's easy to do and you're in that category of early paroxysmal atrial fibrillation, that's why the success rates are roughly in the range of 80 to 90%. But if you actually go in and your technique is to go until you can't wake up the AFib anymore, then you're going to get a higher success rate because you're doing more. And so your success rate could be up to 90 to 95% because it is a continuum of disease, not just these easy early, mid, late classifications. Just like blocked heart arteries is a continuum. If you say, oh, what is early coronary artery disease? Well, that might be a blockage between 10 to 40%. And what's a middle stage lesion, that's 40 to 60%. And then what's a late stage lesion or more severe lesion, that's 70 to 90%. And then of course, completely occluded. So it's a continuum as well, but we have to use categories or just classify and make arbitrary boundaries. But just know that just because you're in one stage doesn't mean you have exactly that number of AFib sources or cells. I've seen people where they have less presenting symptoms, but I had to do a lot more in them than just the back wall. On the other hand, I've had people where sometimes we're pleasantly surprised and they seem to be having a lot more, and then we go in there and get rid of stuff on that first wall, one or two walls, maybe the corners, the pulmonary veins, and then the posterior wall and roof, and then that's it. And we don't have to do that much. And I thought we might have to do more like 5 walls because they're in it 90% of the time. So it's one of those things where how you do it and the correlation between how many cells you have and what you do is important. And unfortunately, because this is such a difficult procedure to get rid of, and because AFib progresses and just gets stronger and stronger and stronger, it's like a forest fire that's just getting bigger and bigger and bigger. A lot of people, if they only do really the four corners, because it's so easy to do these days, and they don't do much more advanced than that, then it becomes an issue of, well, they just do what they can do. And most people, most doctors, they do it anatomically. So this is another difference in terms of your strategy. How do you know when you've gotten enough during the procedure? The vast majority of people tend to do it anatomically. They say, well, the person's in this category, early paroxysmal atrial fibrillation, so I'm going to do those four corners, the pulmonary veins. Oh, if that's all I do, and somebody comes to me with a later stage, persistent or long-standing persistent, well, unfortunately, they'll just keep doing those four corners, the four veins, the pulmonary veins, what we call pulmonary vein isolation. And I've seen some people do that 3 or 4 times and just not get the result. I've seen other people where they can do a little bit more complex ablation, where they can do that, and they'll do that first, anatomically, they'll just kind of do it. And then if you're still in AFib at the end of the case, they'll just cardiovert you or shock you back to normal and then see what happens, and then bring you back if you need more. So if they bring you back, they might do a little bit more complex ablation. They might do the back wall or posterior wall, and then also the roof. And that is definitely a much more complex ablation. And that will get rid of more advanced cases. But remember, that's still only about 2.5 walls out of the 6. That really doesn't involve the floor or the front anterior wall or the lateral wall or the septum. There's still like 4 walls, that 3.5 to 4 walls that aren't being approached by that strategy or technique. And so they'll just say, well, that's the best we can do. They might do that multiple times, get rid of a little bit more, and then end up putting you on an antiarrhythmic drug to suppress the rest. And remember, that could work, but then as you get older, the AFib keeps progressing, and then eventually it breaks through that and you're kind of back where you were. So in my opinion, the more you can get rid of, the better your long-term results. It's never a permanent cure, even if you do extensively on 4 to 6 walls of that chamber out of the 6. But the more you can get rid of, the more you can turn the force fire back to almost 0 or close to it, the longer it's going to take to form back in the walls we didn't cauterize or freeze to get back to where it was. So like a heart artery, if somebody gets blocked up from 10% to 90% and somebody opens it up to 60%, it might do fine with no symptoms for a couple of years, but it's going to grow from 60% back up to 90% very quickly. They actually open it back up to 0 to 10%, maybe they might get another 10 years or so before it gets back up to 80, 90% blockage. So that's the analogy I would use.